Yeah, good afternoon. This is an example of a case which, when you have problems in the post-operative period, you have to review the case by yourself. And again, not only by yourself, you ask your other colleagues, what did I did wrong? And you are supposed to be exposed to a fair trial. This is the 35-year-old female presented by left sudden diminution of vision. She is phakic, myopic -8, anterior segment within normal, other eye is free and myopic. And this was the picture at the start of the surgery: inferior retinal detachment, macula off. And this is the surgery: chandelier assisted buckling, a break and a flap tear at the area of the ora serrata infratemporally, cryo to the break, placement of an encircling band, drainage of the subretinal fluid, and some air in the vitreous cavity to reform the pressure inside the eye. And as you can see, at the end of the surgery, the retina is flat. You can just depress any part of the retina. You can see the retina attached with no problem. And this was the post-operative appearance at different quadrants. The retina is reattached. The buccal is well seen. There's still some bubbles of air in the vitreous cavity, which did disappear in a week. However, 2 months later, the patient returned with this picture: severe PVR with detachment of the central retina. And as you can see, the buccal is still there seen, but the patient now is a grade of PVR grade D. And we have to go back to surgery, try to remove whatever you can of the surface proliferation, and try to see if there is possible area where the posterior part of the retina is attached and there is a circumferential shortening and epiretinal proliferation, which you have to remove. Again, finally, at the end, I was able to flatten the retina under air, what we call the pneumohydraulic test, that assured me that the retina is okay, because I had placed the laser. As you can see, the retina is reattached in spite of the fact that there was some surface proliferation on the surface of the retina, which I could not remove. In the post-operative appearance, the retina was attached. As you can see on the OCT, the macula is attached. However, there are areas of proliferation, especially in the two areas of the iatrogenic breaks, which I did create during the dissection. 3 months later, the central retina is still attached, but if you can see on the OCT, there is starting inferior retinal detachment. The center of the fovea is not detached, but the inferior retina part is starting to detach. So I have to go there with some cataract. To remove the cataract, go for revitrectomy. And since you know the proliferation was a diffuse sheet of subretinal, epiretinal, and intraretinal proliferation, I have to go for retinectomy. And the extent of the retinectomy was determined in this case by the use of perfluorocarbon. I tried to go even into the clean or the healthy areas of the retina. There was dense bands which have to go to cut by the cutter. Finally, the retina was a part of the retina was attached centrally under the effect of the PFC, but as you can see on the nasal side, there is still a diffuse sheet of subretinal, intraretinal fibrosis, which I could not remove. But the perfluorocarbon was replaced by silicone oil for this case. And this was the post-operative appearance. Again, the macula was flat. The inferior retina is looking a little bit ugly because I could not remove the whole proliferation. And this was 3 months later. Again, the fovea is attached. The inferior ugly retina. And I don't know if I have to do with this ugly retina. And as you can see, if I go for more retinectomy, I will just cut the inferior arcade. But the fovea is attached and the vision is around 560. Again, this is another picture of the same case. As you can see, the fovea is attached. Now, the question is, do I go to remove the inferior retina for the sake of attaching the fovea, or I just leave the patient at this point, or I go to what I call usually silicone oil exchange? Thank you.
I go home.
I think we go to the French Congress 2020.
Yes, no, it's working. What about the fellow eye? Because the fellow eye is normal with the good visual acuity. Another operation maybe for the functional result is not...
The point is, if you are going to leave the silicone in this eye for the sake of reattaching the macula, because you have already gained this point, the silicone on the long term will cause problems. You will have band keratopathy, glaucoma, disfigured eye. So this is a balance which you have to decide. If you go for removal of the silicone, but if you are going to remove the silicone, you have reinsert silicone at the same setting. So there is a term which called is refueling the silicone oil. Just remove it and put some more.
I feel we worry about the future of tomorrow. I think now the retina's attached, we leave it, and then tomorrow we worry about the future of tomorrow. I think yeah, I think better for the coronary.
360. She's counting finger around 360.
Okay. My name is Dr. Ungurianov from Moscow. In this case, first of all, it need to remove epiretinal and membrane. So first, we could see you don't to take it posterior hyaloid. So posterior hyaloid later after, because the PVE it's process. First of all, first operation, you can see that it's start, but later this process continue. Under silicone oil, without silicone oil, it doesn't matter. Process started, so it needs to clean the retina, and also then you have very small retinotomy, very small retina in center. So, and laser, this proliferation continue and start much and much. So, in this case, first of all, it need to take out silicone oil, because silicone oil somewhere already under retina in the case. So, remove under PFCL staining. First of all, staining and remove epiretinal membrane as far as you can. And other, what you can do in 360 retinotomy. And keep this eye as long as possible, because first important things, we can remove silicone oil or not can, or cannot, it is intraocular pressure. If you have low intraocular pressure, don't remove. It's safe eye as far as possible. If you have normal, you can do that.
Yeah, thank you. But the problem is that the perforation are so posterior. So if you want to extend your 360 retinectomy, then you will go through the inferior arcades and even to the inferior part of the fovea.
But first of, I said it needs to staining epiretinal membrane and try to clean. After that, only if you can peripheral somewhere, you do retinotomy. clean and clean.
Okay, thank you. Dr. Yusuf.
Can send the case to Moscow. We need your admin.
Yes, this is a very good demonstration of PVR case for Professor Dr. Ashraf. PVR should be prevention better than cure. Okay, I think we can lower the incidence of PVR in such cases by adding circumferential band beside the
It was already there.
buckle.
It was already there.
Okay, then I think doing wide area of ILM will lower the incidence of the central PVR, and I think I have time now for doing injection of methotrexate. I think methotrexate here will get benefits for lowering the incidence of PVR, because this retina will not withstand. This PVR will contract more and the macula will be off sooner or later.
Thank you. Well, thank you so much all for the excellent discussion and for staying late. We're very grateful for your time and all your. Thank you so much. Thank you.